So we're just going to have some case discussions. Let me just, I had something here. All right, you're seeing that, right? Okay. So, sorry, these are my disclosures. So the first case is a 60-year-old female. Sorry that I have different screens, so it sounds like I'm not looking at the camera. 60-year-old female that became diffusely itchy and eventually developed jaundice and loose clay colored stools about 2 to 3 times a day. She went to see her PCP, who show elevated bilirubin and LFTs. He then ordered an ultrasound of the abdomen that showed this mild intrahepatic bile duct and moderate gallbladder distension that was concerning for a possible common bile duct obstruction. Subsequently, an MRI was ordered that actually showed a bile duct dilatation with abrupt cutoff of the common bile duct and now dilated pancreas duct in the region of the head of the pancreas. She then underwent a ERCP with US that actually visualized a 2 by 2.8 centimeters mass in the head of the pancreas, the lesion above the portal vein. There was a single localized biliary structure that was found in the myothird of the main bile duct, and one plastic stent was placed. Unfortunately, the FNA came back with adenocarcinoma. The day after the procedure, she actually presented to the ED with severe abdominal pain that was consistent with post-ERCP pancreatitis. The CT was done, that again showed this pancreatitis, lipase was elevated at 2,000, and she was transferred and admitted. At the time, her bili was still high at 15.7. So these are some of the images that she had. I fast forward just for sake of time, and I put some of the imaging of the PET CT that she had. And you can see this infiltrative mass in the head of the pancreas was probably involving the mesenteric root. There was some concerning for antral involvement and even the second and third portions of the duodenum. And if anyone wants to chime in terms of any other findings that they feel that are pertinent, please chime in. So based on that, she was stage T2 and 0M0. We have the multidisciplinary discussion in our treatment planning conference, and the PET CT findings were concerning for this extension to the gastric antrum that also could be related to inflammation, pancreatitis. She then was started at FOLFIRINOX, which is very appropriate. We heard Dr. Kim's initial presentation, and she completed 6 cycles. Restaging CT scans show encasement still of the common hepatic artery and gastroduodenal artery. At the time, she was back and to have a discussion in the GI tumor board or GI treatment planning committee, and she was still felt to be non-resectable. And you can see here that we have some disputedly enhancing mass in the head of the pancreas that's adjacent to the CBD. There's measuring probably about 2 centimeters. There's also, sorry, I have to move everybody else to be able to see here. The mass was extending superior and encasing some of the portal vein just above the confluence. And then finally, there's also some soft tissue surrounding the hepatic artery here. So what should we do next? Should we continue with FOLFIRINOX based on these findings? Should we refer that to radiation? Should we switch to nab-paclitaxel, or should we refer to palliative care? Does anyone has a opinion here? All right. So I will continue. So she actually then proceeded with 3 cycles of nab-paclitaxel, and the follow-up scan after the 3 months of treatment continues to show this ill-defining mass in the head of the pancreas. Really, there was felt that there was not much change, and the hepatic catheter was still encased. She was discussed again on tumor board, and the decision was to actually explore her. And then she underwent a Whipple procedure with a pathologic report as T1 N1 tumor with R0 resection, but the closed neck margin with a closed neck margin and the extensive perineural invasion. So what's the next step? I mean, she received 3 months of FOLFIRINOX with stable disease, received 3 months of gem-nab-paclitaxel with stable disease on the scans. So after surgery, she recovers, she has a good performance status. What should we do? Should we continue with the adjuvant gem-nab-paclitaxel, even though our adjuvant data that we have on that was not positive? Should we switch to gem-capecitabine? Should we do adjuvant FOLFIRINOX? Now go for radiation or surveillance. These are all the possible ideas that one has, and I don't know if anyone I want to pitch in.
Maybe one of our colleagues from the community wants to chime in so that we can have some feedback from them. I think there's different options here that we could have done. So.
Could do surveillance given through 6 months of chemotherapy.
Okay, I like that idea, and maybe you have done clinic with Dr. Garrido, because that's what she picked. So she proceeded with surveillance, and she had restaging scans every 6 months until about 18 months post-surgery. At that point, there was a small change in the pulmonary nodules that were really not clinically significant, but there was noticed some stenosis or narrowing of the portal vein with increasing soft tissue density in the retroperitoneal adjacent to the SMA and the PV. With that, PET-CT was ordered that show a slight uptake around the area in the celiac trunk with the SUV of 3.3. And here is, I put the CT portion of that. You can see some here and some here. The SUV, honestly, when I was looking at the imaging, wasn't that impressive that I felt that was something that would be obvious to our eyes. So now what? So now we do. So this patient was then sent to a US to confirm if this was potentially a recurrence. That actually came back initially as a highly atypical granular epithelial, possibly compatible with previous adenocarcinoma. That was actually discussed later on in the GI TPC, and it was felt during the tumor board that this was actually a recurrence of disease. There was a discussion with the patient about next steps in terms of restarting treatment and so forth, and she decided to do a watch and wait approach. She had few scans in between, were stable until about 4 months after this documented recurrence that show a slight increase in the left supraclavicular lymph node, and her CA99 actually started to go up. And at that point, the patient and the team decided to start her on back on chemotherapy. And this is, I took away the dates just for HIPAA, but as you can see here, this was her initial CA99 before she started treatment. Then she started some treatment, comes down here, gets her surgery, her CA99 keeps low, and then here, which is about June, July, of this year, her CA99 continues to go up, and she was restarted in treatment, I believe, last month. Her tumor marker, her CA99 was a little bit above 200. So that's the first case. Dr. Garrido, any comments since it's your patient?
To make a quick comment on this graph, the beginning of the graph, it's actually FOLFIRINOX. So you can see that the CA19-9 was not trending down. So we had stable disease, but with a CA19-9 that was going on the wrong direction, which is why we switched chemo backwards. So if we have a stable disease, but with a CAT scan with a CA19-9 that it's trending down, we may not, if the patient is clinically doing well, we may not switch chemotherapies at that time point. But in this patient, things were not going the way we wanted.
Yeah.
And this illustrates also the fact that you may have someone who doesn't respond to gemabraxine, right? But ends up having some response to, who doesn't respond to FOLFIRINOX, but ends up having some nice response to gemabraxine. Also, in retrospect, one will question if we should have offered this patient radiation therapy after surgery with a close margin. As Dr. Lloyd mentioned, patients who have positive lymph nodes or positive margins of resection after surgery are patients that we consider for radiation. In general, we prefer to offer systemic treatment, and it's hard to stop chemotherapy in the middle of the course to offer radiation. But in this patient where we never offer chemo after surgery, it will have not been unreasonable to offer some post-op chemo radiation.
Very good. And I want to ask Dr. King. So Dr. King, you know, Dr. Garrido pointed, and I apologize without the subtitles, but so we often see that sometimes patients can have a stable to increase in the CA19-9 before they trend down. So what has been the practice for you? How long do you follow the CA19-9 because you become impatient that's not coming down?
We typically were following them with scans. Are you talking about post-resection or what?
No, and in the neoadjuvant setting.
Oh, yeah, we follow it every 2 months essentially with scans.
Okay. Okay.
And so if the CA19-9 was getting worse, or if the imaging was worse, showing progressive disease, then we would switch.
Yeah, just because I saw some literature that said that sometimes the CA19-9 may lag in terms of the response, and then, you know, the decision that I think we might struggle is like when to switch it if someone has a stable disease in the scans initially. I think having stable disease in the CA19-9 going up at 3 months, I think is a good point for me, but I just didn't know if you came from a different practice on that.
No, and it was definitely a multidisciplinary kind of a decision. Everybody looked at the images, everybody discussed, well, how anxious are we about this before switching over? I mean, it was not just one person, right? So. Okay.
So case 2. So 56 years old with a history of autoimmune hepatitis, currently on azothioprine, that complained of epigastric pain for about 2 months and a weight loss. In terms of other past medical history, she had a history of cervical cancer, which was treated with hysterectomy. Her family, she had multiple family members with ovarian cancer. They were diagnosing early in their lives, and to the best of her knowledge, she didn't know if anyone in the family had germline mutation testing. So a CT scan of the abdomen was ordered and showed a mass in the body of the pancreas. This mass appears to be unresectable, and there was also, and I'll show the image in the next slide, and also appears to have potentially a lesion in the liver as well. A PET CT was ordered to confirm that, and you can see here the large mass as well as the one of the liver mets that we could see. So what's the next step? Sorry, I gave the first away. So if this history of significant family history, as well as the new guidelines that recommend everybody to be referred to genetic counselor, she did so. And then the tumor was also sent to NGS via Tempus, and she was started on modified FOLFIRINOX. She developed severe nausea cycle 1, for which she required hydration. She also had a cholinergic reaction during neurotical infusion, which actually improved with slowing down the rate of the irinotecan. She had multiple dose reductions to be able to tolerate, and in the end, she was having irinotecan at 120, oxaliplatin at 60, and 5-FU at 1,000. Dr. Garrido, can you comment what is your recipe for your modified FOLFIRINOX? Do you do without the, everybody has a little bit. So what, I assume you drop the bolus And what dose of irinotecan do you use?
Yeah, I use the 150 milligram per square meter, which is the dose that we were using at MD Anderson on all these patients. And then, as you know, when they did the adjuvant trial, those patients after surgery didn't tolerate full doses of irinotecan, so they had to modify treatment and to do 150. So for my metastatic patients, I have always been dropping the bolus and using 150 of irinotecan.
Do you start the oxaliplatin at 85 or you start at 70? I have seen that difference between the colleagues, including at MD Anderson. So I want to see your take.
Correct. MD Anderson, at the time I was there, we were using 75, but I have most often keep the dose at 85 milligram per square meter. But
yeah. Okay, so I think we do the same way. Okay. So then germline testing is back, and she had a pathologic mutation BRCA2. Because of that, you know, she had MRIs and ovarian screening that were recommended. She also her temples, actually, to be honest with the case, she was able to get the NGS testing results before, and this mutation is actually highly suspicious for a germline mutation, which was then confirmed. And these are the other mutations that she had. She was microsatellite stable, and she had low tumor burden of tumor mutation burden. So after 6 months of treatment, she does have some response, both in the primary tumor, but as well in the liver. You can see that her liver lesion is no longer present. So she received 6 months of treatment with modified FOLFIRINOX with significant dose reductions. So now what? What would you do on this patient based on Dr. Garrido's presentation? Anyone want to take a chance? All right.
This is better if we can hear you.
Yes.
We won't until we hear your voices.
And in case anybody's, you know, kind of new to Zoom, I'll remind you there's a microphone logo in the bottom left corner. You can unmute yourself, or you can use your little chat feature and type in a response.
Yeah, I was just looking at the chat. Okay, so I think folks are hungry. So based on the data, the patient was just recently starting on olaparib and is doing well. I believe she's waiting for her first scan. So we'll see how she will do.